Okay, so I'm here to introduce to you a new concept and probably a revolution in spine surgery. The title is Instability is the Issue and Stabilization is the Treatment. For several decades, this is basilar invagination. For several decades, decompression was the treatment. Anterior decompression here and posterior foramen magnum decompression here. This was the first article in the literature in 2004, where instability was identified in this group of patients and stabilization was the treatment. Decompression, however, remained treatment for this. So this was the first article where craniovertebral junction realignment and stabilization were considered as treatment, not decompression. So this is basilar invagination. Realignment is one thing and stabilization is another thing. I consider stabilization as the more and most important issue in this problem. In the year 2009, we introduced a new concept, which is I also consider a revolution in the field of spine surgery, the issue of central or axial atlantoaxial instability. So you please see these slides. This is stability type 1, where the facet of C1 is in front of facet of C2. There is atlantodental interval disturbance. There is cord compression. There is facetal listhesis, and facetal stabilization is the treatment. This is type 2, where the facet of C1 is behind the facet of C2. This is basilar invagination. There is no atlantodental interval disturbance. The whole world will still do foramen magnum decompression for this anomaly. This needs atlantoaxial stabilization. Even when the facets are in alignment, even when there is no atlantodental interval disturbance, presence of Chiari malformation and syringomyelia is an indicator of atlantoaxial instability and needs stabilization. When atlantodental interval is not disturbed in type 2 and type 3, these are central or axial atlantoaxial instability. So basilar invagination, no matter whether it is group A or group B, it needs stabilization. And we have introduced this subject in several articles on a basis of huge number of patients. Now our experience on this exceeds or nears 3,000 cases. So whenever there is, even when there is no atlantodental interval disturbance, presence of Chiari malformation and presence of syringomyelia is an indicator of an unstable atlantoaxial joint. You stabilize and you create wonders. There is no need for any kind of decompression. Even when there is no facetal abnormality, even when there is no atlantodental interval disturbance, presence of Chiari is a clear indicator of atlantoaxial instability. And now we have got several hundred patients where these are treated syringomyelia Chiari without decompression. And I consider decompression as a negative operation and reduction of syringomyelia. So there are several articles. In 2008, we said basilar invagination, syringomyelia, Chiari formation needs atlantoaxial stabilization. And in 2013, we said there is no question, no doubt about it. Similar philosophy I related to degenerative spine. This is one of the very early articles when degeneration of craniovertebral junction was discussed as an issue. Otherwise, there was never an article. Presence of osteophytes, presence of reduced facetal space, presence of buckling of posterior longitudinal ligament. We said that these are not primary events. These are secondary to atlantoaxial instability. Extremely important statement to make. Presence of ossification in the apical ligament is not a primary process. It indicates atlantoaxial instability. It indicates the need for stabilization. Retroodontoid Ossification or pseudotumor was considered to be a surgical issue, direct surgical issue, and number of articles have been written. We said for the first time in the literature, there is no need to remove this retroodontoid tissue, which is like an osteophyte. Atlantoaxial instability is the issue. You stabilize, this will reduce on its own. And there is no question, this was a dramatic article during those days. And after this, there are several articles which discuss this issue. Retroodontoid cystic degeneration is not a primary process. It indicates atlantoaxial instability. You stabilize, this disappears. And this we have published. Retroodontoid pannus is in rheumatoid arthritis is not a pathology. It is due to vertical instability, and you stabilize, this pannus disappears as early as immediate postoperative period. No question in my mind. This concept revolutionized the treatment. Otherwise, transoral surgery was a very in thing for this problem. Vertical instability is the issue in spinal degeneration. Take it from me. Take it from me. This kind of facetal instability for C1, C2 in basilar invagination, everybody knows. We do not know. We never discuss retrolisthesis of facet in spinal degeneration. Reduction of the joint space, bulging of the disc bulges, osteophyte formation, multiple level bulges are not primary events. They are indicators of spinal instability, and they indicate the need for spinal stabilization. This will disappear spontaneously. This is the disc, whole world will come and remove this. But there is another form of treatment, distract the facet, introduce these spacers, and you can treat by facetal distraction. In the immediate postoperative phase, you can have a new disc, ligamentum flavum goes, bulge goes, and the patient improves dramatically. So there are several hundred cases with me now where this ligamentum flavum bulge, facetal disc bulges can go immediate after operation by multi-level facetal distraction as a treatment. And this we published in the year 2011. With these kind of spacers, we introduced similar concept in the treatment of lumbar canal stenosis in 2011. But now we changed. Decompression of compressed or deformed neural system has been the basis for treatment. We do not agree with this. We say that only fixation for spinal cervical spondylosis is the treatment because instability is the cause. I introduced this concept in 2013, and that we recently published our experience with 215 cases with this concept that instability is the problem and stabilization is the treatment. Decompression of any form is a negative treatment. No need to remove this. No need to decompress this. Only need to stabilize this. This is the treatment. And there is no doubt or no question in my mind when I say this with such confidence and such pride that there is no need for decompression. There is a need for stabilization. Atlantoaxial instability is frequently present with spinal degeneration, cervical spondylosis. When you see multi-level spinal degeneration, you never look at C1, C2. When there is no compression here, does not mean that there is no instability. You see, there is a big instability, and that I call central instability needs stabilization. When the patient is remarkably disabled, cervical spondylosis, atlantoaxial instability is very commonly associated despite the fact that there is no compression. Decompression is not the treatment. Stabilization that includes atlantoaxial joint is a magic. You please take it from me. Lumbar canal stenosis, we introduced the same concept. Degeneration is not degeneration, it is instability. Even when there is a huge osteophyte or disc bulge, it is an indicator of unstable spine meriting the need for stabilization as a form of treatment. Ossification of OPLL, nobody in the world knows treatment. The only treatment described is decompression. we introduce a remarkable, probably a revolutionary concept that atlantoaxial instability is very common phenomena in OPLL. This is OPLL. Decompression is the treatment. You do laminoplasty, you do corpectomy, and all kinds of decompression it has been indicated in the world literature. I am saying with great pride and pleasure that these patients need only stabilization, and decompression as a form of treatment is a negative form of treatment. Is only stabilization a form of treatment for OPLL? Absolutely. And there is no doubt. And there are several papers where we have mentioned our experience as only spinal fixation as a treatment for cervical myelopathy associated with posterior longitudinal ligament ossification. You see, there is ossification of posterior longitudinal ligament, and there is an instability here, even when the facets are in alignment, even when there is no manifest or radiologically identified instability, even when there is no compression at the C1-C2 junction. Presence of OPLL such high is an indicator of atlantoaxial instability, meriting the need for stabilization and absolutely negating the need for decompression, whether it is anterior and posterior. Both these forms of decompression are negative forms of treatment. This is an OPLL. This needs atlantoaxial stabilization and subaxial stabilization, decompression, laminectomy, removal of osteophyte, removal of disc, introduction of corpectomy or laminoplasty are negative forms of treatment. Atlantoaxial and subaxial spinal fixation, can it revolutionize the treatment of OPLL? Absolutely, absolutely. Can decompressive laminectomy for degenerative lumbar and cervical canal stenosis become historical? Absolutely. Is instability the nodal point of pathogenesis of both cervical spondylosis, myelopathy, and OPLL? Absolutely. I am introducing before you, I am introducing before the World Spinal Column Society an absolutely alternative, revolutionary concept. And you please carefully read these lines. Decompression is never primary. Decompression is always secondary. Treat the primary. Decompression is never a form of treatment. Thank you very much, my dear friends.